Great.
Thank you so much.
So it's 2 o'clock, everybody. So let me go ahead and kick things off and welcome everybody. Thank you for joining us. This is the Alternative Payment Methodology and Measurement-Based Care Work Group. My name is Jeff Vanderplug. I'm the CEO at the Child Health Development Institute. I'm joined by Tim Marshall, who is a co-chair of this group, as well as Eric Schwartz, who is a facilitator for this APM group. So we thank you, Eric, for being part of the team and helping us out in that capacity. So we're laughing about this because we were just clearly defining roles right before the call started. So you have the agenda in front of you on the screen. Just as a reminder of our goals, we wanted to take a look at various approaches towards APM and behavioral health. We wanted to familiarize ourselves with current and planned initiatives in our state around APM, with a few of those examples in parentheses, and then ultimately make recommendations to the Behavioral Health Plan Advisory Board and the 12 State Department commissioners for further follow-up. This is the 5th of our 6 planned meetings. Today's objectives, we want to learn more, and we're welcoming, hopefully, if she's not on already, we will soon be welcoming Vicki Veltri from the OHS, Executive Director of the Office of Health Strategies. And she wants to share with us some information around prospective payment models in primary care, which includes some behavioral health elements. And we're also very pleased to be joined by Dr. Henry Chung from New York State, who's going to share with us information around APM approaches taking place in New York. So with that, I will turn it over to Eric for any other further welcome and introductions, as well as Tim Marshall.
So I just want to welcome everybody. Just a reminder, I think in the chat, if you would put, rather than obviously going around the room and doing introductions, if you would put in the chat, your name and title and what agency you work for, and that everybody then can have a look at that rather than going around the room. So again, welcome everybody. Jeff's right. This is the 5th meeting of the 6th. I think the next meeting, and I'm going to go a little bit ahead, but the next meeting I believe is November 17th. I'm not exactly sure what time we're meeting. I don't know if it's the same time, but
it's still 2 to 3.
Okay, so November 17th, so you can put that in your calendars. Yes, today we have, did Vicki come on?
Yes.
Yes.
Okay, there you are. So what we have is Vicki Veltri to spend some time from the Office of Health Strategy. And then Dr. Henry Chung after that on APM modeling for pediatric populations. And just a reminder, I think this is intended to give us information and to generate conversation and discussion with the different speakers, questions, and in order to help us form the recommendations that Jeff was just talking about. So we want to be mindful of everybody's time. And so I don't know, Tim, do you have anything you wanted to add before we get going?
No, thank you for all for joining, and we can jump right in.
Okay, so we're gonna start with Vicki. And Vicki is the Executive Director of the Office of Health Strategy. And she was appointed to serve as the first head of the agency in February of this agency in 2018. She was reappointed by Governor Ned Lamont in 2019 to oversee the office's mission to implement comprehensive data-driven strategies that promote equal access to high-quality health care, control costs, and ensure better health for the people of Connecticut. Her extensive experience prior to this role included serving as the Chief Health Policy Advisor to Lieutenant Governor Wyman, and prior to that as the state's healthcare advocate. So welcome, Vicki, and we look forward to your presentation.
Thank you, Eric. I was going to say, cut it. To my old boss, who would constantly go like this when people were doing her introductions. Anyway, thanks for having me, everybody. I thought I would just, I had been talking to Jeff and Tim and folks and wanted to give people a brief update on some of the work we've been doing in our office under Governor's Executive Order number 5. So I'm going to put up a slide deck, but I'm going to whip through slideshow. And you guys will have to tell me if you can see this on your screens. from the beginning. Is it going? Uh-oh. Can
Not
you
yet.
see anything?
Not yet.
Okay, my screen is circling and circling and circling. So let me just start by saying the governor has executive order number 5. It's been in place since last January, the previous January 2020. And it directs OHS to set cost growth benchmarks, to set a primary care spending target as a percentage of all medical expenditures. Oh, there we go. And to create quality benchmarks. And these apply to healthcare systems with large provider entities. And they apply to the insurers, including the state employee plan and Medicaid. I think I said, yeah, the insurers and the large systems and provider entities and the entire commercial market. So that's sort of the background. I decided I would skip through some of these slides at the beginning here to just try to get to what I'd like to get to, although it's not advancing even on my screen. I'm not sure what's going on here.
I can share on
are
my,
you seeing any? Oh, can you? Please,
Yep.
I'm so sorry. I don't know what's going on here. Let me just stop it. Okay, so I will just say, as in terms of primary care, as a state, the governor has set a priority that we do a better job resourcing primary care in the state of Connecticut, which is woefully under-resourced. There's lots of statistics on that. We have a primary care shortage in the state of Connecticut that is deepening, and we're worried about that as we want to be able to get problems ahead of time, and we'd like people to get quality care in their interactions with both pediatricians and adults with internal medicine and other providers. So if you could just go right on to slide 10, I think it's 10, where the roadmap begins, that'll be good. Okay, so primary care, there is a primary care spending target, and the idea is that we would double our spending as a share of medical expenditures by 2025 from where we are now, which is only about 5% on the dollar overall, to 10% by 2025. Having said that, Medicaid, and I see bills on, is already at somewhere around 10% already. So the Medicaid program is ahead of us in terms of, as a state as a whole, in terms of the level of share of spending on primary care. That said, the target is nice, but the target is really not the end in and of itself. The target was set to incentivize improvement in primary care resourcing in a way that makes sense, to advance primary care and do a better job delivering patient-centered care. So we've started developing a roadmap for primary care. We started meeting with the primary care subgroup in 2021, earlier this year. And the idea is to make recommendations, as I said, to make primary care more effective and efficient, better meet the needs of the patients, address the issues that the professionals are telling us are very real. And when I say the professionals, I mean actual providers that we've met with, many primary care providers and pediatricians across the state of Connecticut, as well as their associations about the deepening problems in terms of primary care resourcing. And we want to do that in a way that allows some flexibility to people who want to volunteer to engage in these models, so they can spend more time with patients, feel like they're equipped with the supports they need, and to deliver a patient care experience that is a good experience for our patients and address many needs that go beyond clinical needs. So with that, if you could go to the next slide, I'd appreciate it. Probably just a page down, do it on the keyboard, right? So we had talked about we have multiple steps in this roadmap process. And I want to stress, this is a roadmap. We are not embarking on anything tomorrow. We're trying to develop a roadmap in alignment with our practitioners, with our patients, with our Medicaid program, with our state comptroller's office, and with the commercial payers, because we know patients move in and out of coverage options, and we need to move the ship together to do this right. So we wanted to develop first an advanced primary care practice model, and that is a way to set core functions. What should practice teams be able to do to be eligible to participate in a voluntary model that gets them kind of resources and technical assistance to achieve a better primary care system. So the next slide gets to the kinds of functions we are asking primary care practices to achieve, to be part of this voluntary model. So these are the core practice functions. They're not surprising probably to all of you. They're similar to NCQA's PCMH program, not identical, but similar. And there are two of them in particular I want to talk about for a couple minutes. So next slide, please. I think these slides were shared, so hopefully you can review most of the details later. This is just high level right now. But two of the core practice functions that we think are absolutely critical are team-based practice, because what we have heard repeatedly is, and from both sides of the equation, right, is the practitioners don't have enough time to spend with people, and they're on a fee-for-service wheel where they get 10 minutes and they have to run the patient in, run the patient out, and they're addressing a specific problem that the patient presents with. They're not necessarily getting to other things the patient wants to talk about or needs to talk about that are not necessarily delivery related, care delivery, but are definitely related to their health. For instance, a housing need, an employment issue. So we are looking at team-based practice that includes community health workers, that may include a nutritionist, a pharmacist on the care team, and of real importance, a behavioral health practitioner. We hope to be part of this. So we have talked a long time as a state, I think, about integrating behavioral health and primary care. There are multiple ways to do it, and there are multiple ways to do it for different patient populations. But for the purposes of this model, we are looking at behavioral health integration through having clinicians that may be part of the practice who can provide that assessment, brief treatment, and referral. And they would be doing screening and potential referrals for substance use treatment. This is not going to substitute for, if somebody has intensive needs, it needs to be referred to a provider for more serious conditions for ongoing treatment, but at least embeds behavioral health into the primary care practice. We think those are absolutely critical functions. So how do we help providers do that? So next slide, please. One of the things we're looking at is supporting these practices. So I can say to you now, you want to be part of a model, great, you have to do it. How are the practices supposed to achieve that with some kind of assistance? Some of the larger systems may be able to do this with minimal help. The smaller providers, much harder to do that. So we would be providing, if you go to the next slide, assistance with practices to do that. So to maximize the core functions and be able to achieve the ability to do the core functions, there will be both practice coaches, which we would have to contract for, OHS would contract for under this voluntary model. And the practice teams would have to work with a practice coach to be able to achieve the ability to participate in this model. And then secondly, a learning collaborative among the organizations. We've had learning collaboratives before when we did a clinical and community integration program. It was very successful. The providers really enjoyed it. We would have to fund, obviously, practice coaching and a learning collaborative. So to be continued on that, we are looking at potential budget resources for that for this year if we continue this roadmap. But next slide, please. Did it go? Did it go? Did you guys see the next slide, or is it not? Okay, now I can't remember what it is, or I would tell you. But okay, so we're gonna have these practice coaches, we'll have the learning collaboratives. The two things that I want to emphasize to people here, because I think there's some misinformation floating out there, is that we are looking at these, and we've heard loud and clearly from providers, not everybody's ready to do a prospective payment model. Many people want it, not everybody. So the idea would be voluntary prospective payment model for those who want to go into a voluntary prospective payment model, in which many of the services are provided and paid for through a bundle, and or a potential fee-for-service path where providers who want to stay in fee-for-service could be in fee-for-service through this model, but they would have to agree to achieve these functions, these capabilities as practice teams to get these enhanced payments that we would offer them and incentive payments if they succeed in their performance. So this is a very, very high level way of telling you that we are working very hard to try to improve the primary care space, incentivize providers to develop these practice teams, but do it in a way that makes sense, that delivers this high quality patient-centered care and rewards the practices who do it well and who want to commit to doing it. But it is a voluntary model. And that's the direction we've chosen to go, and is likely, and I'm not sure the range of folks on the call, is probably a compromise between those who think we should do nothing and those who want us to go to complete total cost of care models. And there are some total cost of care models in place in the state where the primary group, primary practice team, or accountable care organization is responsible for all of the care of the patient beyond the four walls of the primary care practice. But this model is tied to primary care services, not specialty. I saw a question in there. It is not a total cost of care model. So it's not an accountability for total cost of care, but it is something to get us down this road of better team-based practice, better attention to primary care, better attention to social drivers of health that people present at their practitioners' offices with every day. And it is voluntary. So those are the main parameters. I realize that was a lot in a short period of time. Suffice it to say, we are working hand in glove alongside Bill and Brad Richards over at DSS to make sure we are aligning ourselves, at least on parameters. We are not directing Medicaid. We cannot direct Medicaid or any carrier for that matter to participate in this model. That is a decision that any payer would have to make here. But we are hoping that we're laying groundwork for some transformation in primary care. So with that, I guess I'll stop and open it up if anybody has questions. I'm
Vicki,
sorry that was so fast.
Did we miss any slides that you wanted to talk about? Because I know
I don't know. Well, I will say on the implementation side of this equation, this is a roadmap, right? So we're developing a roadmap. We anticipate to put out a draft roadmap sometime in November for public comment. We'll come back and finalize a roadmap. But then we would get into discussing an implementation plan for 2022, and not that it would all be implemented in 2022, but start a process of discussion on rolling out an implementation plan to make these models real and get people in them who want to be in them. The other piece of this that there was one slide on, and I want to make sure I get to, is that we've had a lot of discussion over the last few years on community health with hospitals, with providers, with patients, with community groups about the need to address upstream much, much more. And I know Inc. has some, and who's following me is someone from the New York Inc. model, I think. We feel really committed to developing community health models that are tied to these primary care models that incentivize upstream investment and encourage that linkage with primary care so we can really get these problems up front, ACEs, conditions that relate to people's health addressed at a community level where there's potential accountability at a community level to drive interventions that then can feed into the primary care space. And I think of places like Oregon that has CCOs, other places like that, where there's a lot of upstream attention that the state needs to really incentivize and put some effort behind. And I think all of us are doing it in one way or another, but we're trying to bring those efforts together through some upstream investment and hopefully the development of some delivery and payment models that can maybe pay people for keeping people healthy, as opposed to just paying people for when people are sick or ill. So that's the next iteration of work that we're doing with a community group that we have is working alongside the primary care group.
Vicki, do you have some ideas about how the work that you've done you might propose some components of that might align with a behavioral health alternative in Connecticut?
You know, I've been thinking about this, and I think I'd love to have more discussion like with Bill and Brad and folks offline about how we can beef up integration, true integration of behavioral health with primary care. We've seen models around the state, separate models, and we know DSS funded and DMIS worked on health homes and was very successful. In fact, seeing patients where they are, coming in one door, and also being able to access primary care. And or we've seen some hospitals, I know Hartford Healthcare has embedded behavioral health clinicians in some of their primary care practices. That is the future, and I think it has to come together. We have to open up these practice teams instead of looking at siloed practitioner models. We really need to open it up, but to do that, we have to be more flexible in the way we allow people to engage in our models of care. And unfortunately, sometimes that means moving away for fee-for-service in some respects, not all respects, but I think likely has to happen to some degree.
So I think there's a couple of questions from Cheryl in the Lescarbo in the chat. And one is, how does the number of behavioral health clinicians align with the requirement to have one in each practice that wants to participate? And I think related to that is, how would most primary care practices would love to have a behavioral health clinician in their practice, but cannot find or afford the staff under current reimbursement rates. How will these be addressed?
Yeah, so, well, I mean, it depends on which route the practitioner would take. Under a prospective payment model, team-based practice is based on a budget. It's a bundled type of payment. So it is a capitation type payment that is based on the number of patients that the practice has, and it's multiplied by basically the number of services we think they're going to have, some risk adjustment. There's a whole series of calculations that goes into that payment. And that payment is intended to pay for the team, right? So if there's a community health worker on the team, a behavioral health clinician on the team, they are paid via that mechanism, right? So that's how you would get payment to, let's say, a community health worker or a behavioral health provider who's in that practice. So that one is a little easier. On the fee-for-service side, you'd have to make it part of the fee-for-service structure. And then reimbursement rates, I mean, that becomes an issue between obviously the commercial carrier. I know there are concerns on that side of the equation that have been brought to my attention most recently with respect to LCSWs that would have to be addressed. There's no question. But in a fee-for-service model where a provider chooses to remain fee-for-service but can still demonstrate that the core functions are met, we'd have to deal with that via the carriers. There's no question. We would have to have that discussion. So in terms of the number of clinicians, I don't think we're looking at embedding psychiatrists, let's say, or psychologists. It's more likely you're looking at embedding an LCSW, maybe an LADC, an LPC. So at that threshold of professional, the payment structure should be able to accommodate that, particularly through the prospective payment model. But it's still a TBD, and is why we don't have a plan. We don't have the implementation plan yet. We're just looking at the high-level roadmap at this point. So there's still a lot to be discussed. But the reason I wanted to discuss this with all of you today is to just let you know this is happening on the primary care side, and we're looking at this embedding of behavioral health practitioners in the practice because we felt it was critical, and we want to be able to support DCF and and everybody else, our state agency partners and everybody on the phone here, on the direction DCF is taking. So we don't want to duplicate, but we want to at least align our work to make sure we can meet the demands that we are seeing out there, which are huge. And there are some people who will benefit better in this model, I think, lighter touch, maybe screening and referral. But I think people with deeper needs are not going to get all their needs addressed in the primary care setting. But at least having a screening referral, a screening assessment and referral will allow attention to be paid to it, which is less likely to be done right now under the existing models of care.
Great. Okay, I want to be mindful of our time since we have another presenter. Are there any other questions for Vicki before we move on?
Heather has one.
Okay.
Yep.
Hey,
Hi,
Heather.
Vicki, how you doing?
Good, how are you?
Good. So really a question. I'm really interested in the state working on the reverse of what we're talking about in the primary care settings where we're trying to integrate mental health care, because we need to look at how to introduce the capacity for behavioral health providers to deliver primary care within their settings, particularly for those of us where we're really the health home for many, many individuals, including children and adults. And we are doing this at CHR with federal assistance, but we need to recognize that for those individuals who have very significant behavioral health conditions, they will be better served by getting their primary care needs met within the context of a broader sort of health home model and the behavioral health provider. So I just urge the state to be looking at, it's been very one directional, and really look at the model of integrated care, and without needing to go down the road of becoming an FQHC, which is simply going to cost the state more money.
Yeah, I don't disagree with you, Heather, because, we're looking at this as it is not the panacea solution for all residents of the state of Connecticut to have integrated care. It is directionally supportive, I think, of us trying to resource primary care better. It is not necessarily a solution for people who have, more intense needs and who are going to come in the door, like I said earlier, on the behavioral health side, who need primary care practitioners available to them there. So I don't see any reason to not have other models that accommodate that are tied to this model in some way. But this is mainly a primary care model with some connection to behavioral health care. It is not going to be the solution, I don't think, for everybody to behavioral health access issues and primary care issues for people with serious and persistent mental illness who come in the behavioral health door. You're right. They should be complementary in my view.
Great. Well, I want to be mindful of our time and our guests. So thank you, Victoria. We really appreciate it. Very interesting. And, if anybody else has questions, please put them in the chat and we can certainly forward them and have Victoria and Vicky address them. Okay.
Yeah. Thank you. Call me Vicky, please.
Oh, Vicky, sorry. So the next person on in our meeting is Dr. Henry Chung, who is a professor of psychiatry at Albert Einstein College of Medicine and formerly from the senior medical director for behavioral health integration strategy at Montefiore Case Management. Currently, Dr. Chung is a leading consultant in national and regional initiatives focused on the implementation, policy, and financing of the integration between primary care and behavioral health. So right up what we're talking about. He has extensive experience across multiple healthcare sectors and is a past recipient of the Lewis and Jack Rudin Prize for Medicine and Health for his contributions to the New York City healthcare delivery system. And so Dr. Chung is going to talk about and do a presentation on APM modeling for pediatric populations, the NCK program in New York. So welcome, Dr. Chung.
Thanks so much, Eric, and thanks so much, everyone, for the invitation. Let me ask Elise if she can just go ahead and put up my slides and we can get going. I think the lead in by Vicky, I think, is really quite important to understand because, from a population health perspective, the logical place has always been to start with primary care. And that makes a lot of sense. I've spent most of my psychiatric career working in primary care settings. So I'm very familiar with all of that work and the importance of that work. But when you start going down the road to pediatrics, from an accountability and an APM perspective, you've got a lot of challenges. Because by and large, the work that we do that is so critical for children and families is largely preventive. And there are not a whole lot of cost savings. And in most accountable care models, the focus is primarily on adults where there are achievable cost savings. So just by virtue of the fact that children are children and people are looking for cost savings, children often get ignored in APM modeling. That's one big problem. The other problem is the nature of this particular work group that I'm speaking to today, which is focused on behavioral health. So now you're even another step removed in terms of the nature of the dollar and the nature of the accountability, despite the fact that behavioral health practitioners have critical roles to play for both pediatric and adult populations. So this is really a challenge. And in New York, because we've been awarded with our state, DOH, Department of Health, the Integrated Care for Kids model, which is a CMMI initiative, I'm prepared to share with you some of our thoughts about this and potentially have a discussion with you, because the presentation won't be long at all, have a discussion with you all, sort of brainstorm about how we can be a little bit more creative as it relates to pediatric behavioral health. Or if you want to go into adult behavioral health, I'm happy to do that as well, since I'm doing a lot of work in that area of reverse integration, the idea behind rewarding behavioral health providers to do more primary care related activities in those settings. So let's go to the next slide. So we'll discuss a bit about my lead-in, the pediatric specific challenges. I'll give you a high level, very high level on the New York APM design for BINC. BINC stands for, by the way, Bronx Equity. That's our local name because we are located in the Bronx borough of New York City. So I'll give you a high level sense of our APM design. And then I'll share with you some of my leading thoughts, which are yet to be fully developed around what I consider incremental APM strategies where the role of behavioral health is absolutely critical. And hopefully we'll engage in a bit of a discussion. Next slide. Okay, so clearly in your work in behavioral health, you'll be going through this checklist, because APM always includes the target population. It always includes the types of needs that you're proposing to serve within the APM design, what specific outcomes you're going to commit to, either quality or cost or both. Which are the key populations to start with, because in general, before you go into a total cost of care model, you want to incrementally have some subsets of the population that you can build some wins with. So that's very, very important, this notion of intentional incrementality. And then, of course, the notion of partnership, because at every level, to be successful in APM, you actually need to include a whole lot of folks to be successful, both providers and consumers, as well as regulators. Next slide. So from a CMS perspective, in the INC model, Integrated Care for Kids, they are giving us full latitude, recognizing the challenges in children in terms of what I talked about. Perhaps not a whole lot of dollars, focus on prevention. So they're giving us a continuum to work through. And any of these potentially can qualify for being a successful INC model. Pay for performance, a bundle payment approach, shared savings with no downside, with upside, and then a full risk capitation model or prospective payment. So these are the kinds of things within the continuum that we can do within the INC model. Next slide. And as I said before, there are unique considerations for pediatric APM. Children and youth, not only are there perhaps less cost savings across the board, even in Medicaid, but remember also that children and youth are served in so many more settings, particularly high need children and youth are served in so many more non-health settings where the criticality of those services impinge upon the health outcomes of the children, right? So what are we talking about? Early intervention services, school, child welfare, and on and on. And you have lots of these related services that quite frankly have not been within the Medicaid dollar, if that's primarily where you build your APM. So this is a challenge to kind of figure out, include people like that, provide the value, but also figure out, okay, how are you going to sort of build an accountability model that is not levered only for, say, the pediatrician, because the pediatrician can only do so much. And your work group certainly understand the role of the critical role of behavioral health. But there are benefits to trying to think through the APM, and that's what we're doing in New York. You know, we're trying to, first of all, understand that there could be longer term savings down the road, and is there a way to capture that? There could be spillover savings as a result of intervening with the child and family unit that actually accrue to the adult side of the ledger, naming the parents or caregiver, that maybe you need to lever. There's a data infrastructure that in building the APM is so critical to bringing in those data sets that I just talked about, child welfare and school health and others, where you have to work through all the permissions. And of course, you have to bring together the consumer stakeholders and other stakeholders who are really interested in looking at quality measures, because quality measures in pediatrics, again, largely focus on prevention, but have a key role to play in terms of the premium dollar in New York Medicaid and commercial payers. And so quality measures, you know, may be the linchpin to getting good APM started, even if you don't have cost savings. This is very, very important to consider. In New York, high scoring health plans on quality get large premium adjustments that are incredibly meaningful. And therefore, pediatrics can play a role in that space. And I think we have to sort of be mindful of that. Next slide. Okay, so high level, in terms of what we're doing with the New York Inc. project, at Montefiore, which is the community lead for the Inc. project, we have a lot of experience in ACO work over the past 15 years or so. And so we're kind of used to thinking about things in a total cost of care mode. This is a total care cost of care roadmap, if you will, that we've envisioned for the Inc. model for kids. And the way we're thinking about it is that from a population perspective, you can segment the child population into two buckets. On the left would be the essentially, I'll call them healthy, again in quotes, children who don't appear to be high cost in the moment and don't appear to have significant risk factors for chronic illness. So that's in sort of what we call the service integration level 1 tier. And we've surmised that maybe about 75 to 80% of the Medicaid population of kids is going to be in that bucket. But we've also surmised that on the right-hand side, about 20 to 25% of kids will have demonstrated risk factors that are evident in either diminished quality of care and or utilization that is largely preventable. Think asthma, think depressed kids, think kids that have attention deficit, think of healthy steps. So when you think about that segmentation, what we're saying is that we should really be developing two types of APMs within a larger APM model for the population. If you segment the population, then the service integration level 1, that is generally healthy Medicaid kids, there's a much greater weighting on being successful on quality measures, meaning well child visits, having routine primary care at the appropriate intensity for their age level, depression screening, immunizations, preventive STI, any of that work that is largely preventive in nature, including some quality measures like asthma control and things like that, we're going to more reward the dollar for the achievement of higher quality, recognizing that there may not be much cost savings in that particular segment. And on the right-hand side, because we have evidence that there are kids that use the ED a lot, think asthma, think sickle cell, and behavioral health. And there are kids that actually are admitted to the hospital, think sickle cell, think behavioral health. that there are cost savings there to be achieved, and the weighting of the incentive, if you will, would be evenly split between the quality measures as well as savings. And that's the basic approach that we're taking. We have yet to implement this. We're in full discussion with the state and our managed care partners, health plan partners, to sort of road test these assumptions with data. But that at a high level is what we're talking about. Now, the devil's in the details with regards to how the dollar, if there were savings achieved or quality dollars achieved, how would you flow that to, say, our behavioral health friends? It's all in the attribution. It's all in the, how do you give credit to your partners who had a role in driving either cost savings or driving quality care? So we have yet to work that out, but we acknowledge that it won't all be at the level of the primary care provider. We have to be able to move some incentive dollars to, say, our behavioral health providers. And so we can talk about that in a discussion, how we might consider doing that. There's no downside in this model in the first few years, by the way. So that's the other thing. Next slide. These are some of the CMS performance milestones in Inc. And if you look at this from a behavioral health perspective, you might look at this and say, well, gee, we play a role in this stuff, right? We could potentially help our primary care providers to assure that if we're seeing young children or new moms in our settings, we can help with making sure that they get well child visits in terms of working on that care coordination front to support our pediatric colleagues. We could certainly do that for well child visits. Adolescent well care visits is abysmal across the board in this country, as many people know. Once you go beyond sort of the typical immunization schedule, adolescent well visits just drop off a cliff. So that's another place where our behavioral health colleagues could really be helpful. ED visits to some degree, certainly. Follow-up after hospitals and mental illness, certainly. First-line psychosocial care for children and adolescents, antipsychotics, definitely. Screening for the clinical depression or follow-up plan, definitely. So you can see here that behavioral health providers can meaningfully contribute to the performance of these quality measures, which typically accrue to the credit of the pediatric provider, but can also accrue to the benefit, if you will, of the behavioral health provider. And we would need to sort that out. Next slide. So one of the things that we're testing in advance of this total cost of care model, which I think could be of interest in my discussion with Elise, is that you can start with smaller type APMs and build that confidence level to move forward. One is the Healthy Steps model, which largely focused on 0 to 3, but quite frankly, my friends at National Healthy Steps can tell you that, you know, it can probably go to from 0 to 5 easily, right? It doesn't have to restrict to 0 to 3. The bottom line here, in terms of the services that makes Healthy Steps so difficult to fund from a value-based perspective, is that the tier 1 services, which are largely preventive in nature, that support, you know, at-risk moms and dads with bonding and things like that, are done without a clinical diagnosis. So you need to find a way to support, you know, some of these non-billable prevention type stuff that we know is going to pay off tremendous dividends down the road. And so one of the things we're working on is a type of bundled monthly supplement idea to practitioners that will do the Healthy Steps model and ensure that there's a level of engagement and intensity in the model, which they will get paid for as a monthly supplemental payment. And in return for that monthly supplemental payment, which is over and above fee-for-service, so over and above a E&M visit, over and above a psychologist visit, but it's really sort of the glue that keeps Healthy Steps working, the navigation, stuff like that, is this monthly payment. But in return for that monthly payment, the health plan gets back a commitment to improving the quality measures that we talked about. So you know those quality measures I just talked about, well child visits? Yeah, Getting some screenings done, including postpartum screening within the first first year of a mom delivering. Yeah. So these are meaningful things that have value to our health plans because their premium is significantly bumped with their quality scores in New York State. So there's an inherent incentive to try to fund models where there may not be cost savings, but you can generate high quality. So that's just an idea that we've got right now that we've put into a grant recently. We'd like to work it out with our health plan partner and begin the pilot early next year in advance of our total cost of care model in Inc. That's one example that we're talking about. Next slide. And I won't go into all this. You guys know the Healthy Steps model, but you can just tell looking at this that even though it's largely a primary care-based model, if you look at all of the other circles, these circles are usually beyond what primary care can do. And this is, again, where the partnership with behavioral health providers really are critically important. And if we get these extra payments, once again, figuring out how that payment is provided to all the parties that had an impact on that patient in the Healthy Steps model will be one of the challenges. Next slide. This is, in fact, the bundle payment proposal. I just said all of this verbally. You have this in a slide. This will be distributed to you after in the PDF. So you guys can kind of take a look at this. And but essentially, this is what we're talking about in terms of what I described. Next slide. All right. That's kind of what I wanted to share with you, knowing that you guys are relatively early in your APM work and the challenges of behavioral health providers and pediatrics. So I wanted to leave a lot of time for us to engage in a discussion about either anything that I presented or anything that you guys might want to explore as it relates to this area, because I have a keen interest in it and certainly a national and New York State related perspective on this.
Wow, that was fabulous. I certainly much appreciate it. Any questions? Bill, anybody? Heather?
So I have a question. So is there any data, Dr. Chung, any data anywhere that demonstrates, because I know coming from a child provider, right? You know, and I have some experience in another state from doing alternative payment kind of models and pay for performance. And the question always is, and you sort of referenced it in the beginning, is there any data that demonstrates that alternative payment models actually results in cost savings in kids APM models? Is there any data anywhere that says, yes, if you go down this road, you know, I can see the quality part, right? I can see the quality part, but is there any data that says, oh yeah, we should keep going down this road of alternative payment models in kids systems because it does create cost savings?
The answer is that yes, and it started, that evidence base is starting to grow. So, but they normally relate to subsets as opposed to total population peds. So the subsets where it's meaningful would be kids with asthma, and there's certainly a pretty decent literature around APMs for that subset, because you see the excess generation, if you will, of ED visits and inpatient hospitalizations for what is largely preventable if you provide a modicum of care management and more intensity in care coordination. And then the other area is in sickle cell, where you know, that is extremely high cost per capita. Sickle cell is probably one of the highest cost things that affect our kids, particularly African-American kids. There is a little bit of data emerging, but it's not quite as clear. And this is around kids and health homes, because the savings typically accrue outside of the healthcare system. So for example, if you can you know, prevent one kid from going into a residential setting, that's a huge amount of savings. That data is really early. and I don't think anyone has figured out yet, at least to my limited knowledge, how to sort of cost, if you will, the savings of something that sometimes is outside the Medicaid dollar. And that's really the trick, is that what is typically counted as savings is typically within the bucket of what is Medicaid spend. And with kids, that sometimes that is, as you know, not the case. It's child welfare, for example, is typically not in the Medicaid dollar. So if you prevent one child from going into foster care, what does that mean? I mean, so these are some of the real world challenges of doing population-based APMs for kids.
I also have a question for you. Thank you for a great presentation. You were starting to hint at maybe, and I could be wrong about this, that you may have some ideas about how to address the issue you raised, where you have these integrated care approaches that are resting, attribution rests with primary care or with the medical side, but you're bringing in behavioral health partners. What are your initial early thoughts on how to structure payments to the behavioral health providers in that collaboration? Because you were suggesting that there are ways to do it, but I'd love to hear more ideas about the mechanics of getting some of the cost saving payments down to the behavioral health side. Right.
So, probably the best analog to this would be the collaborative care model on the adult side. And if you think about it from either a Healthy Steps perspective or go beyond Healthy Steps and think about it in the context of child adolescent work in general for behavioral health providers in primary care. First, there is who pays the specialist who goes there. So let's assume, listening to Vicky's early presentation, that in the advanced primary care model, your agency, Jeff, is willing to provide licensed clinical social workers to 4 pediatric providers in your area. And you're willing to provide essentially what is a leasing arrangement. So the question is, who bills for that encounter in the pediatric provider's office? The rules kind of all over the map here, even in New York. In most cases, the pediatric provider can actually bill that on behalf of the provider, on behalf of the behavioral health provider. And that payment would go in total to you because you provided the staff member. So assuming that happens, that you can get paid for that. And if that can happen, and if from a regulatory standpoint, you have to bill for it, then you bill for it under your rates. Now, it could be that, like in New York, the rates are better if the behavioral health provider bills it. For example, in New York, our APGs, our payment codes, are better if the behavioral health provider, who is a licensed facility, bills on the New York Medicaid. It's a better payment than if the pediatric provider bills it in their regulatory structure. So that's what we would recommend doing if we had the latitude to do it. But there's another payment, and that is the navigation piece. So every person you see in behavioral health, largely with kids, is complex because you're engaging school, you're engaging family members, because no kid is a silo. So you're likely going to need some additional care management support for a large segment of those kids. And that is that extra payment that I talked about, this bundle, this additional monthly supplemental payment. And our view is that monthly supplemental payment should be split in some portion to the behavioral health provider, who is likely to take on a lot of that care management capability. Because why? Because the behavioral health providers in your agencies, generally speaking, are better at doing the social services stuff, looking at the full range of needs from a health home standpoint that the family may need. What if the mom needs counseling on top of that? Again, you're better prepared to do that stuff. So that's the rationale, and that's the way that we would see it in terms of what we're proposing right now in our grant initiative and with our health plan partner. And by the way, Jeff, you had a question about obesity. Obesity is a great one. It is not in the CMS measures, but adolescent obesity is, and childhood obesity is so well linked to eventual depression, eventual behavioral health disorders, eventual diabetes, and other significant high-cost conditions. That is clearly going to be one of those preventive services that I think behavioral health providers can uniquely play a role. Our pediatric providers just don't have, not that they're not interested, they're great people. I love pediatricians, by the way. I've worked with both internists and pediatricians. Pediatricians they are just out there, but they just don't have the resources and the wherewithal to really focus on this stuff. And again, that's where a behavioral health provider organization with adequate training and adequate interest and motivation, and that is outcomes oriented, can really play a role.
Okay, well, we have about 4 minutes left. Does anybody have any other questions for Dr. Chung? Or I don't know if Vicky is still on here, if for Vicky before we start to wind down. If someone sees a hand, let me know. I don't see any. Okay, so I want to thank Vicky and I want to thank Dr. Chung for their presentations. They were excellent presentations, and I think generated some good discussions, some good questions, and can provide certainly provide some opportunities for us to continue on the journey of having recommendations for the state around alternative payment models. So if there are no other questions, Jeff, Tim, do you have anything to add?
Yeah, actually, I just wanted to say, appreciate in New York, Dr. Chang coming, because we could look for maybe potential future partnerships. I know the Connecticut Inc. folks are also on, and there seemed to be some potential crossover and interest in some of the activities here. So we appreciate both presentations. So thank you all for coming too. Jeff?
Nothing further for me. Great presentations. Thanks everybody for being part of this. And Tim pointed out that we do have our friends from Connecticut Inc. I just want to acknowledge kind of like the collaboration coming together, this work group together with Clifford Beers Inc. It's been a pretty cool collaborative approach that we want to see continue as Inc. Connecticut continues to progress and develop, and as the state continues to consider approaches that they can proliferate across the state. So a lot to digest today. I know my head's sort of like swimming with lots of ideas and thoughts, but appreciate everybody joining us today.
All right, and just a reminder, the next meeting is November 17th from 2 to 3. All right, thank you, everybody.
Thank you all. Have a great day.